So we'll continue with discussing um, hematologic disorders. So the first one we'll talk about is sickle cell disease. This is an inherited disorder that affects red blood cells. It's very predominant in those with African, Caribbean, and South American descent. It's present less common in Mediterranean and Middle Eastern. All newborns in the United States actually get tested for the sickle cell disease shortly after birth. So what happens with sickle cell disease is that people have red blood cells that are no longer nice and round. They actually become very misshapen, and that leads to dysfunction in oxygen binding, and then you end up getting unintentional clot formation. The clots may result in a blockage known as vaso-occlusive crisis. This results in hypoxia, pretty substantial pain, and can lead to organ damage if not fixed very quickly. So normally sickle cells have a very short lifespan, resulting in excuse me, quite a bit of cellular waste product that's just floating around in the blood and can contribute to further clumping. Maintaining hydration is extremely important because if patients with sickle cell disease become dehydrated, that could lead to increasing clumping as well. Complications that are associated with sickle cell disease, anemia, gallstones, jaundice, splenic dysfunction, and then vascular occlusion with ischemia. So this can cause acute chest syndrome, which presents with hypoxia, dyspnea, chest discomfort, and fever, stroke, joint necrosis, specifically the head of the femur and the humerus are very prone to that, pain crisis, acute and chronic organ dysfunction or failure, retinal hemorrhages, increased risk of infection. Many of the complications of sickle cell disease are very, very painful and can lead to life-threatening issues. The patients are very susceptible to infection. You can see on the screen the lighter pink colored cells. Those are the sickle cells. And you can see the other red blood cells there for comparison. So quite very misshapen. So clotting disorders. The first one we'll talk about is hemophilia. This is actually relatively rare. Only about 20,000 Americans have the disorder, and hemophilia A mostly affects males. People with hemophilia A have a decreased ability to create a clot after an injury, which can end up being life-threatening. Patients with hemophilia A typically end up getting IV factors. It's actually factor 8 in order to replace what they don't make naturally in their body. And this will help the blood clot. And they tend to have some of this with them because if they start bleeding, they may not have time to get somewhere to end up getting this factor 8. Another clotting disorder, thrombophilia. So this is when the body is unable to maintain smooth blood flow through the venous and arterial systems. You end up getting a concentration of particular elements in the blood, which creates clogging or blockage issues. So you end up getting clots, essentially. Thrombophilia is a general term for many different conditions that result in the blood clotting more easily than normal. And these could be inherited or genetic disorders, medication, or other factors. And then patients with cancer are also susceptible. Clots can spontaneously develop in the blood of the patient, and so it's something that we have to keep a pretty close eye on. Deep vein thrombosis is a type of clot that we see out in the field. It's a common medical problem in patients that don't move around a whole lot, and then in patients who have had recent surgery or a recent injury. You may encounter several methods to prevent blood clot formation. These include blood thinning medications, warfarin, Coumadin are some of the big ones. Compression stockings, how your blood actually gets back up to your heart from your feet. A lot of that has to do with muscle contraction, actually squeezing that blood back up to your heart. And so if you put on compression stockings, it already has that started, and then any mild um, flexing that you do with your leg muscles will help move that blood a lot easier, and it also prevents pooling. And then mechanical devices as well. Risk factors for a DVT, recent history of joint replacement, any complaints of leg swelling, those that travel, especially truck and long distance bus drivers, somebody that flies an awful lot is higher risk as well. And then somebody that's bedridden, particularly those that are in nursing homes. So in order to treat it, we use anticoagulation therapy. So in hospital IVs will be started first and then transition over to oral medications before they're discharged. There is some subcutaneous injectables that you can take, and oftentimes people that have had recent surgery will end up going home with these shots to give themselves, um, just to make sure that they don't have any issues. Oral medications are typically administered for at least 3 months after diagnosis of a DVT to keep it from happening again. Patients that are prescribed medications for DVT are at increased risk of bleeding complications, particularly gastrointestinal bleeding. And then minor trauma is more likely to result in severe internal or external hemorrhage. So we have to be very careful and ask people that have any sort of trauma if they're on any sort of blood thinner. The problem with DVTs is that they tend not to stay in the legs. They end up traveling, and they can go to the lung, causing a pulmonary embolus. They can go to the brain, causing a stroke. They can go into the heart and just cause all sorts of problems. So this is a life-threatening problem. For taking care of patients that are having hematologic emergencies, first and foremost, seeing safety, just like everything else. A lot of those patients that have sickle cell disease will have had a crisis before and are well aware what's going on. At a minimum, you need to have some gloves on, throw on some eye protection just to keep yourself safe. We're going to determine the number of patients just like anything else, be alert for possible trauma. And then you really want to consider ALS for somebody just because they can provide pain management that EMTs can't provide. If necessary, go ahead and perform spinal immobilization, form your general impression, check for adequate breathing. You may want to ask your patient if they aren't aware that they have sickle cell disease, are they in pain and then of African American or Mediterranean descent, because that might help you steer in the right place. As far as general impression, is the patient anxious, restless, listless? Are they apathetic or irritable? Make sure that you determine a level of consciousness because that might tell you how bad off they are. For airway and breathing, provide high flow oxygen via non-rebreather, trying to over oxygenate those cells that are working. Patients experiencing a sickle cell crisis may have increased respirations or exhibit the signs of pneumonia. If they're having significant breathing difficulty, open the airway. If you need to, you can insert an airway adjunct. Obviously, probably not an OPA because they'll probably end up gagging on that, but you can certainly put an NPA in. And then administer oxygen and assist ventilations as necessary. For circulation, patients with sickle cell crisis have an increased heart rate so that they can actually force those sickle cells through some of the smaller blood vessels where they would get stuck. Um, for suspected hemophilia patients, be alert for signs of acute blood loss, that pale, cool, clammy skin, weak pulse, and then low blood pressure. Note bleeding of unknown origin, so nosebleeds, bloody sputum, or blood in the urine or stool. And make sure that you are alert for signs of hypoxia, which can be secondary to blood loss. Make your transport decision. Transport to the ER should always be recommended with any patient who's experiencing a sickle cell crisis or a problem with their hemophilia. For history taking, we're going to investigate the chief complaint just like we would with anything else, obtain a history of the present illness from anybody that can give you information, and be alert for physical signs that indicate sickle cell crisis, such as swelling of the fingers and toes, priapism, which is an erection that doesn't go away, and then jaundice. You should also ask the following questions. Is the pain isolated to a single location, or is it felt more systemically? Are you having any visual disturbances, any nausea, vomiting, abdominal cramping, or pain? Do you have chest pain, shortness of breath? And then obtain your sample history from a responsive patient if possible, and then you can always fill in the gaps with a family member. Have you had a crisis before? When was the last time you had a crisis? How did your last crisis resolve? And then any recent illnesses, unusual amount of activity, either increased or decreased. And then how has your stress been lately? Has it been about normal, or has it been increased for some reason? Your secondary assessment you want to systematically examine the patient. You want to focus on the places where a lot of your cells are going to congregate. And so this is going to be in your major joints. Evaluate and document the patient's mental status using the APPU scale. Vital signs, you want to definitely get an O2 sat level. Normal sickle cell crisis vital signs, normal to rapid respirations, a weak rapid pulse, pale, cool, clammy skin, and low blood pressure. You want to use a pulse oximeter if available so you can actually monitor their O2 saturation. Keep in mind, though, that if the patient is severely anemic, you might not get an accurate reading. For reassessment, vitals frequently, and make sure that you reassess the mental status. Check to make sure ABCs are still intact. See if they respond to any interventions. A lot of times we're just going to put them on oxygen, and then document any changing. Hospital care for sickle cell disease is pretty much going to include analgesics, penicillin to treat any infections, IV fluid for hydration, and then if they're really, really severe, they may even do a blood transfusion. Hospital care for hemophilia is going to be IV therapy to treat hypotension and transfusion of plasma. They might get some factors as well. Other emergency care is mainly supportive for the symptoms. Patients with inadequate breathing, we're going to put some oxygen on them. We're going to transport them in a position of comfort rapidly to the hospital where they can be adequately taken care of. This is all we have for chapter 19.